All in all, we have about 6 talks. The last set of talks being double acts, and they will bring much needed country perspectives. First, we're going to get an overview of the guidelines themselves before hearing a little bit more about the studies that inform the recommendations, and then leading on to a piece of work that is looking at implementation research on DR-TPT. Our first speaker will be Dr. Avinash Kanchar. Avinash is a medical officer in TB prevention, diagnosis, treatment, care, and innovation at the WHO, and he's been involved in policy development and support for programmatic management of TPT, TB infection prevention and control, and digital technologies for tuberculosis. Avinash, you're able to share your wonderful slides, and then we can take it away.
Yeah, thank you. Okay, thank you very much. As Lele mentioned, I will start by providing the overview of the updates that we recently published. And this includes the guidelines themselves and the associated operational handbook that we now publish with all the latest guidelines that come out of Global TB Program. So, but before I do that, let me take you through a bit of evolution of TPT guidance from WHO. And many of you would be aware, this is one area that WHO has been giving guidance way back since 1993. And since 2011, we have been doing evidence-based guidelines. For the first time in 2015, we consolidated all the recommendations that were spread across different documents. And until then, it was more of a use of isoniazid among people with HIV and children who are contacts of TB patients. But in 2015, there was a broader review that happened, and although the focus remained on low burden and high income countries, we had recommendations on shorter TPT regimens. We had also recommendation on use of tests for infection. In 2018, we expanded the scope of the guidance, and these now apply to all settings and also the high burden countries. And we had a recommendation beyond the use of isoniazid. We had 2 shorter regimens, 3HP as well as 3RH, that was recommended already, along with the recommendation on tests for TB infection. And as Dennis mentioned, WHO continuously keeps tab on the evidence as it emerges. In 2020, we updated the guidelines and included 2 more regimens, 1 HP and 4 months of rifampicin. And now, since we had conclusion of the 2 landmark trials, TB-CHAMP and VQUIN, we have an update that got published just a few weeks back. So we now have included the recommendation for DR-TPT. But while we do this, we also evolved the guidelines, and we have been consolidating all the recommendations and making them as user-friendly as possible, and listening to what countries experience. So just to give a brief, this latest guideline now has 21 recommendations, and as in the past versions, they follow the cascade of care approach. We have recommendations on identifying people at risk of TB and hence who should be considered for TPT, recommendations on ways to screen for TB and ruling out TB disease, tests for TB infection, and then recommendations on the TPT regimens. Along with this, we also highlight the key research gaps that still exist. So for the first set of recommendation on identifying individuals who should be considered for TPT. So these are the ones, many of them you are familiar with. People with HIV, we recommend TPT across all age groups, adults and adolescents, infants who are in contact with a TB patient, children who are more than 12 months in high transmission settings, and also children who have successfully completed a course of TB treatment. Among the contacts, we have always recommended children under 5 years, but since 2018, we also recommend individuals aged more than 5 years who are in contact. And also, we have been recommending TPT for contacts of the drug-resistant TB patients. And in addition, there are other risk populations that need to be considered. People who have silicosis, those who are initiating on anti-TNF treatment, or dialysis, or preparing for transplants. Prisoners, healthcare workers, immigrants from countries with high TB burden, homeless, and people who use drugs should also be considered for TPT. And you'll note some of these recommendations are asterisks, so which means these are strong recommendations that need to be considered by all programs. At the bottom, you'll also note a recommendation which is stricken off, and this was a negative recommendation that we had in the previous version for individuals having diabetes or using alcohol, tobacco smokers, and underweight. And we have taken this out and replaced with some explanation in the guidelines, and this is to encourage generation of more evidence and having a clear recommendations going forward. For the second set of recommendations on the ways to screen people for TB and ruling out TB disease, traditionally we have been encouraging use of symptom screen. For people with HIV, we have this 4 symptom screen of weight, poor weight gain, fever, current cough, and history of contact to person of TB, with TB. This similarly for adults as well, we have a set of 4 symptoms that we have been encouraging. But in addition, we now also have recommendations for use of chest X-ray, C-reactive protein, and WHO recommended rapid diagnostic tests. And we draw these recommendations from the TB screening guidelines, which got published from the 2021. So the second edition of TPT guideline, you will find all these recommendations together. For household contacts as well, in addition to symptom screen and use of chest X-ray amongst both contacts more than 5 years, as well as children, is now recommended. And you will see those 2 recommendations in a different shade, which again are the new recommendations from the 2021 screening guideline, which also encourages use of chest X-ray and the WHO recommended rapid diagnostics, meaning expert and or TrueNat. So for testing for TB infection, we have been recommending TST and IGRA for a while now, but recently we also reviewed the new antigen-based skin tests. So 3 products were reviewed, and they were recommended for use. So we have more products, and one of these antigen-based skin tests has recently cleared the Global Fund ERP and will soon find its place on the GDF catalog. So it should be accessible to countries very soon. However, we don't we consider testing and as not necessary for children who are under 5 and people with HIV. So lack of availability of these tests should not deter programs from expanding programmatic scale-up of TPT. The recommended regimens for TPT, we had these several regimens now, and the asterisked ones are the stronger recommendations. 6 to 9 months isoniazid, 3 months isoniazid rifampicin weekly, 3 months isoniazid rifampicin daily, and also the shortest 1 month isoniazid rifampicin, and 4-month daily rifampicin. So in addition, now we have this clear recommendation on use of levofloxacin for 6 months for individuals exposed to drug-resistant TB or rifampicin-resistant TB. So just to just to bring back the focus to the latest recommendation for DR-TPT, you'll remember in the previous version, we did have a recommendation which was based on very low certainty of the evidence and a conditional recommendation asking countries to consider TPT among individuals exposed to DR-TB. But this was based on individualized risk assessment and more on clinical justification for start of TPT. But now, after the 2 clinical trials that I mentioned, we have a clear recommendation for contacts exposed to drug-resistant and rifampicin-resistant TB to consider 6 months levofloxacin daily as TPT option. There were a few other changes that we made to the guidelines. 2 recommendations for screening among people with HIV were integrated because they were part of the pathway for screening and TPT among PL-HIV. So this is more to simplify the way countries interpreted the recommendation and implemented. And the recommendation on the TPT regimen, it was split based on the strength of the recommendation. So we have 2 recommendations instead of 1 that we had in the past. And then we have adjusted the text of several recommendations aligning to the current terminology that we use at the Global TB Program. So instead of TB disease, we are using TB disease instead of active TB and TB infection instead of latent TB. So we also published this operational handbook, which provides more complementary details for programs, more hands-on tools and job aids, covering areas like contact tracing. You'll find more information on drug dosages, drug-drug interactions, management of adverse events, management of interruptions of TPT, and also monitoring indicators. In this version of the handbook, there are few new things. One is weight band drug dosing for all the TPT regimens, which you'll see in the next slide. We have adjusted the algorithm to incorporate the new screening tools that I mentioned from TB screening guidelines. We have more updates on the adverse events and the management of the adverse events. And then we have collated some best practices from countries, showcasing the great progress that has happened over the past few years. So in this handbook, you'll find that we have weight band based dosing for all the TPT regimens and for all the different formulations that are now available. For example, on this, we have for 3HP, we have the 100 milligram dispersible rifampicin available now. 100 milligram isoniazid and 150 milligram rifampicin, and we'll see dosing starting from under 3 months and 3 kgs up. So all the age groups are now covered, and 3HP can be used with the availability of these new formulations of dispersible rifampicin and isoniazid. Similarly, for levofloxacin, you'll see advice on use of dispersible tablets as well as the solid formulations across all the age groups. And for 1HP, unfortunately, we don't have any new evidence, and so the dosing recommendation still stays beyond 13 years of age. And as I said, the algorithm is adjusted for the screening tools that are now recommended, including the C-reactive protein, chest X-ray, and rapid diagnostics. And also now we clearly emphasize the role of the testing among individuals who are contacts and more than 5 years and other risk groups. So in the handbook, as I said, you can find several important tools like this one to monitor, to define the completion of TPT regimens, and also there would be similar content to add to monitor the to assist in the TPT when treatment interruptions happen. There is also an investment case which was recently launched, and we have highlighted this as an advocacy tool to emphasize with the program managers for asking for more investment, both in the screening as well as TPT expansion. All of this new content that I mentioned you'll soon find it on the TB knowledge sharing platform, and this will also have more details on the more evidence that has gone behind each of the TPT recommendations, and also this can be accessed on a mobile device. And I will close by reminding ourselves about this application that WHO developed, which and we have a newer version of this to Prevent TB app for monitoring the cascade of care, and it has tools to monitor the interruptions of TPT as well as adverse events monitoring. So you can find these new modules in this version, and you can access it on the QR code and the links here. So I'll close by thanking the national programs and the guideline development group and my colleagues at WHO and the donors. Thank you.
Thank you so much, Avinash. We have quite a few questions, as you can imagine, for you in the chat. I can see that most of them you do cover in your recommendations, and your presentation, did describe the sort of challenges very well. But also, I imagine that some of those answers can be found in the handbook. But there was an interesting question here that I think maybe we can pose to you. What is the guidance for healthcare workers exposed to XDR?
Thank you for the question. As of now, we don't have a clear recommendation on individuals exposed to XDR TB. But for healthcare workers, we do recommend TPT in general. And we do recommend testing for the source cases in general. But for XDR TB contacts as such, we don't have a clear recommendation for now.
Thank you. Can we just have the next speaker bio?
Without much ado, I would like to invite Stephanie Lowe to take the next presentation on community perspectives on preventive therapy for drug-resistant TB. And Stephanie is a postdoctoral epidemiologist at McGill University in Montreal, Canada. She has an expertise in qualitative and quantitative methods to explore the socio-cultural aspects of TB care, and with a focus on the role of trust between TB patients and their healthcare providers over the course of treatment. Okay, so Stephanie, over to you.
So let me share my screen. So thank you very much for having me here today and the organizers putting all together. I will be presenting on TPT acceptability, feasibility, values, and preferences of MDR-TB household contact persons. Just briefly to introduce it, values, preferences, and perspectives on the acceptability and feasibility of TPT among MDR-TB contact persons were considered as part of the GDG discussion back in December last year. And to support this discussion, we conducted a rapid qualitative study with 36 MDR-TB household contact persons in 5 high-priority MDR-TB countries. And this was done between September and November. So as you can see, it was a very, very rapid study. In terms of the methods, so for inclusion into our study, we had household contacts of a person diagnosed with MDR-TB within the past year, 18 years of age or older at the time of the interview, and they had to be eligible for TPT according to the WHO guidelines at the time. We had a non-representative but purposive sample where we aimed for maximum variation by age, gender, and experience with TPT. All the interviews were done one-on-one via Zoom, Microsoft Teams, WhatsApp, or phone. The ones in South Africa specifically were done in person. All interviews followed a semi-structured interview guide where we asked first about TB and MDR in general, as well as prevention. Then we had specific questions on TPT acceptability, where we varied the parameters of the TPT regimen in terms of its efficacy, duration, frequency, and risk of possible side effects. So in total, we had 36 participants across 5 countries: India, South Africa, Georgia, Indonesia, and Vietnam. About half were female. Median age was 41, ranging from 21 to 67. Majority were employed. 30% had a chronic condition, which included diabetes, cardiovascular disease, chronic gastritis, joint pain or arthritis, and HIV. 9 people had been offered TPT. Of these, 2 were offered TPT for drug-sensitive TB, and both accepted it. And then 7 were offered TPT for MDR, and 4 accepted it. And this was the 6-month levofloxacin regimen. And of those who did take the MDR TPT, they described it to be acceptable and had minimal side effects. So moving to the findings. So when we got people to think about TPT acceptability, they were really trying to decide whether or not they would agree or disagree to take TPT. And this came through as a decision-making process where they considered 3 main elements. So first, it was their own values. So is taking TPT something that's valuable or important to me? Next, they would consider their preferences. So if there is something important to them, would they accept the threshold for the effectiveness requirements and potential risks of TPT? And then finally, feasibility. Do they think they can actually complete the treatment? So I'll go through each of these. So first, values. Is taking TPT something that is valuable or important to me? So to look at the values, we're going to look at 2 opposing groups of extremes in our participants. So the first group are the people who said absolutely yes. So these are the people who would say yes and accept TPT regardless of the parameters of TPT. So the efficacy, side effects, etc. And then on the other end, you have the people who were absolutely no. And so they would say no to TPT, and it didn't matter what you told them about the regimen. And so the main values that really came through were first, the seriousness of MDR-TB and its treatment. So on the yes group, you have somebody who says, I would feel so bad if I got MDR-TB, it would be very painful. TPT is a good thing because I have younger grandkids and we don't know when they will catch it. And on the other hand, you have somebody who says TB and fever are similar. For the fever, we have medicine, and for TB, we do have medicine. Next is TB transmission and their perception of their susceptibility to TB and the risks. So somebody from South Africa says, anyone can get the TB bug, especially when you share spaces the way we do. We use public transport and we work with people. As a parent, I have to make sure that I am healthy for the sake of my kids and make sure that I don't put others at risk. And on the other end, you have somebody from Georgia who says, when my husband had TB, we shared the bedroom with each other and it was not a problem for me. I'm sure that even this exposure to TB from my daughter cannot lead to my problem, and I cannot transmit this disease to others. I'm sure of it. Then you have the importance of disease prevention in general. So somebody says, if this treatment can help me, why would I say no? These side effects are nothing if it means staying healthy and being alive with my family. And on the other hand, you have somebody who says, people are supposed to take medicine only when they are diagnosed with TB. If somebody is not having any symptoms and no TB, why should one take the medicines? Then you have their overall trust in medicine. So somebody says the doctor knows best. So whatever they give, I have to take. Even if the doctor gives me the poison, I will take it. And then on the other hand, anything can happen. Even if we are told these are the only side effects, other side effects can still happen to our body. And then finally, it's considerations around the health and well-being of others. So this person says, I will never change my opinion because without such treatment, I will get the disease. I can transmit this disease to others and I don't want to do so. And then this other person, also from Georgia, says, if I take this treatment, I will not be able to take care of my daughter. I need to be strong and I cannot have any side effects. You can see here where values around health and well-being of others can kind of flip you from being a yes or a no and go both ways. So what we learned from here is that values can override the perceived benefits and harms of TPT, meaning it didn't matter what you told them about the TPT if their values were not aligned with the concept of TPT. Values do intersect and are not mutually exclusive. And finally, context does matter. So for example, we found that our South African participants highly valued TPT, and this is likely due to their greater familiarity with MDR-TB in terms of both the disease and the treatment because of what they've seen in their own communities. So next we have preferences. So if TPT does align with their values, what would be their threshold for the effectiveness requirements and potential risks of TPT? So we found that most participants would shift the decision, so from a yes to a no or a no to yes, when you change the parameters of the regimen in terms of the effectiveness, the side effects, duration, and frequency. So, for example, this person says, I will take the drugs if I have the 100% guarantee. When I have the cold or flu, for example, I know that taking the drug can solve my problems 100%. That's why I'm ready to take these drugs. But if only half the people may have benefit from TPT, I will not take such treatment. The effectiveness or efficacy of TPT affected the threshold for other parameters. So if, for example, the effectiveness was told to be 100%, then they might accept all sorts of side effects and costs and duration. But if you start to lower the effectiveness, what we found is that most people will start to say no to certain types of side effects, or if the cost exceeds some sort of threshold or the duration is too long. Acceptability really varied based on the perceived impact of treatment on quality of life. So things like whether or not they believed it would disrupt the daily routine and responsibilities, whether there's a risk of any kind of stigma, or interaction with other medications or chronic comorbidity. Aside from the efficacy of the regimen, the most important attributes were side effects, followed by duration of treatment, and then finally the frequency and pill burden. So as this person says, I can take even 1 year of any medicine, but I'm afraid of the side effects. And then lastly, you have feasibility. So even if they said yes, it aligns with their values, and yes, they can accept the regimen profile, they have to believe they can actually complete the treatment. And so the 4 main things that people talked about were the out-of-pocket expenses and whether or not they have financial resources or support. So this person says the transportation fees sometimes are a problem, because TPT is going to help me and my family, then we will find a way to get the money for the travel costs. Then it's the clinical follow-ups. So my only concern is I have a 3-year-old daughter, so I keep her in the house when I visit the hospital. So that's the only concern, to leave her alone. Social support. I think the support and the encouragement from the family members or friends, that's really important. If I forget something, then there is the close people around me. And then finally, we have counseling and education. People will take it, but some might say, I am not sick, and maybe stop halfway. That's why I said they need to be told what will happen if they are not adhering. So in conclusion, acceptability of TPT was really a decision-making process informed by somebody's values, preferences, and feasibility considerations. MDR-TPT was acceptable and had high social value among our participants in the 5 different settings. And the most acceptable regimen will have high effectiveness in preventing MDR-TB, mild side effects that don't interfere with daily activities, few pills, less than daily and short duration, minimal and convenient clinical follow-ups, and low socioeconomic costs. And I would like to thank my team at McGill University and all the study investigators and research staff in the 5 countries, as well as participants of the study, for sharing their experiences and perspectives. Thank you.
Thank you very much, Stephanie, and 10 minutes to the second. So that was great. So there is one reaction to your presentation here about what about acceptability of TPT by household contacts other than children and people with HIV?
Other than, or you mean children and people with HIV?
So I think it's other than children and people living with HIV. I guess it's
other. So in our sample, we didn't have any children, and we did have somebody, at least one person, who had HIV. So I can't really speak to children, but I know that the team in South Africa has done a lot of work with children in their study. But I think that in general, when it comes to something like HIV or other comorbidities, the people's concerns really, besides everything else that everybody else thought about, is the risk of interaction with their current drugs that they're taking. So they might think that either it would make their side effects that they already experience from their other drugs worse, or they're worried about taking too many pills, or at the same time, or that the scheduling of their treatment might not work together with what they're already taking. So those are the considerations, but I don't know that it's specific to HIV versus just people who have chronic illnesses and are on chronic medications.
Okay, thank you very much. So back to you, Lele, for the next speaker.
Thanks, Dennis. But next is a talk on the combined analysis of efficacy and safety data from TB-CHAMP and VQUIN trials. And the presentation will be given by Dr. Trinh Duong. Trinh is a medical statistician with more than 20 years of experience. She's a statistical lead on TB prevention studies at the MRC Clinical Trials Unit at UCL, and she was the lead trial statistician for TB-CHAMP and the project lead for the combined analysis with VQUIN. Trinh, please share your slides.
Thank you very much, Lele. So hi, everyone. So I'm really honored to be able to present the combined analysis from VQUIN and TB-CHAMP on behalf of the two trial teams. So many of you will already be familiar with these two landmark studies, which were randomized phase 3 trials evaluating levofloxacin as preventive treatment for household contacts of drug-resistant TB. And right from the start, the two trial teams collaborated to prospectively plan for a meta-analysis of the two studies. We know that obviously pooling data increases statistical power. Here, it will also allow us to compare the safety profile of levo between adults and children. So VQUIN was based in Vietnam, and it was conducted by Sydney University in collaboration with the Vietnam National TB Program. In total, 2,041 participants were enrolled with household exposure to drug-resistant TB and who at the time of screening did not have TB disease. Most of the VQUIN participants were adults, so 92% were aged 18 years or above, with the overall median age of 40 years. TB-CHAMP, on the other hand, enrolled 922 children from South Africa. The trial sponsor was Stellenbosch University, with UCL having trial management and stats responsibilities. And the CHAMP cohort was mainly under age 5 years, since initially only this group was eligible for the study. So the overall median age in CHAMP was around 3 years. Apart from this, the two trials had really similar study design, which was remarkable given that they were conceived separately by the trial teams. So in both, participants were randomized at household level in 1-to-1 allocation ratio to levo versus placebo, taken daily for 6 months. In VQUIN, participants were followed up to 30 months, and in CHAMP, most participants were followed up to 72 weeks. For the combined analysis, all methods were pre-specified before the results were known for either trials. And for the primary outcome, this was defined as confirmed or clinically defined TB by 54 weeks, including TB-related death. In the primary analysis, we first of all used standard individual participant data meta-analysis approach to estimate the treatment effect across the two trials, assuming that levo efficacy was the same in the two study populations. However, we wanted to also allow for the possibility that levo efficacy may differ between VQUIN and TB-CHAMP. Therefore, we carried out additional Bayesian analysis to estimate the treatment effect within each study populations. And this was done using a novel approach that allowed us to borrow information across the two studies in order to increase power compared to the corresponding analysis of each study. So to estimate the treatment effect in VQUIN, we borrow information from TB-CHAMP and vice versa. So looking at the results from the primary IPD meta-analysis, based on nearly 3,000 participants. In total, there were 8 participants in the levo group developing a TB endpoint by 54 weeks compared to 21 in the placebo group, giving an overall hazard ratio of 0.40, confidence interval 0.17 to 0.90, and corresponding p-value 0.03. So showing evidence that levo reduced the risk of TB by 60% across 1 year in the 2 studies combined. It's worth noting from the Kaplan-Meier curve shown here that in both studies, the TB incidence in the control group was much lower than expected. So these are the dotted lines shown here, which meant that individually, each study had lower power than they were originally planned for. And this is likely to be the reason why in subgroup analysis by study, we get estimated hazard ratios with wide confidence intervals, as shown here, that span the null hypothesis value of 1. So each study had estimates that had low precision. As mentioned earlier, the Bayesian analysis provided more power, so gave us estimates with tighter intervals, reflecting better precision for the treatment effect and showing stronger evidence that levo was effective within each of the study population. And as you can also see, the Bayesian estimates for VQUIN and CHAMP were very similar, so 0.41 and 0.38, suggesting that levo efficacy was very similar between the 2 study populations. And in case anyone is wondering whether this is a little bit of a magic trick that you're seeing, remember that all methods were pre-specified before the results were known for either studies, as mentioned earlier. TB disease during overall study follow-up was a secondary outcome. In total, there were 41 endpoints. What's really interesting to see here is that is to see the timing of the endpoints. So during the first 6 months, there was only 1 endpoint in the levo group compared to 14 in the placebo group. While after 6 months, the number of endpoints was exactly the same in each group, so 13 in each group, suggesting that during the treatment phase, levo was highly protective. But once participants come off treatment, there didn't seem to be a longer-term effect. Moving on to safety analysis, we looked at quite a wide range of safety outcomes since we were obviously keen not to miss any safety signals, given that here we're giving preventive treatment to a population that's otherwise well. For most of the outcomes, we did not see evidence of a difference between the treatment groups, so that's very reassuring. Here I'm just going to highlight some key results. First, the number of participants with grade 3 or above adverse events was very similar between the treatment groups, so 43 versus 42. For grade 3 or above adverse events, at least possibly related to study drug, again, overall, we do not see a difference between the treatment groups. However, looking at by study, in VQUIN, there were more participants in the levo arm with such events than those in placebo group, so 10 versus 2. While in TB-CHAMP, we did not see this difference. In both studies, early discontinuation of study treatment due to adverse events occurred more frequently in the levo group than placebo group, so there was around a 6-fold increase in risk. Most participants, however, stopped treatment for low-grade events. And in TB-CHAMP, the number of participants who were affected was very small, so 6 versus 1 in the 2 groups. However, as you can see in the histogram here, the likelihood of stopping treatment for adverse events increased with age, reaching around 8% among older adults on levo. And in addition, the difference between the treatment groups, so that's the red versus the blue lines, are much more apparent among adults and adolescents and not so apparent in young children. Many of you will know that musculoskeletal events is a potential concern with levo use. Here we see that levo is associated with increased risk, but only in VQUIN and not in TB-CHAMP. Nearly all musculoskeletal events were of low grades. There were very few grade 3 events, and the number of these was similar between the two arms. Again, there is a really clear trend with age, with the risk increasing with age, reaching around 25% in older adults on levo. And similarly, the difference between the treatment groups can be seen among adults and adolescents only. So to summarize, the pooled data from these two really complementary trials have shown that levo taken daily for 6 months reduced the risk of TB by 60% over 1 year among household contacts of drug-resistant TB, with similar efficacy seen for adults and children. And interestingly, the protective effect seems to be restricted to the treatment period. The safety results are obviously really important, and here they were very reassuring. However, among adults and adolescents, we did see that levo was associated with low-grade events, particularly musculoskeletal events, leading to treatment discontinuation. And finally, I think it's worth mentioning that the importance of early collaboration between the two trial teams here, which have really helped us to be in the position where we're at and being able to present these important results in a really timely manner. And also it's really exciting to see the role of statistical methodology and what that added to the overall analysis. Lastly, just to thank everyone involved in the two trials and the combined analysis, and especially the PIs from CHAMP and VQUIN, so Anneke, James, Simon, and Greg. Thank you, everyone.
Thank you so much, Trinh. Just picking up a question for you from the chat. It's quite a lively chat, I must say. There's a question here that says, in the two groups of contacts of those who developed TB, what were the proportions with DS-TB and DR-TB? Are you able to say a little bit about that and maybe link to it? I think there's an interest in the chat to know whether levo can be used for DS-TB. So some thoughts on that.
So sorry, so of those with the events, did you say?
Yes.
Of the proportion? I think the majority was where we have the information was DR-TB. There might possibly been only one with DS-TB for CHAMP. I'm not sure offhand what is the data for VQUIN.
Okay, thanks. That was a quick answer. So let's see. Dennis, do you see any other quick question for Trinh? If not, I think we can proceed to the next speaker. Yeah.
No, I think we can move ahead, yes. Okay, so the next speaker is Professor Greg Fox, who's interim director of the Sydney Southeast Asia Center and director of the NHMRC Center for Research Excellence in TB at the University of Sydney. Professor Fox is a respiratory physician at Sydney's Royal Prince Alfred Hospital with more than 15 years experience leading clinical trials and research relating to infectious diseases and chronic diseases. And his presentation, which I believe is on a recording, is on the impact of levofloxacin prevention therapy on microbiome and acquired drug resistance. So this touches upon at least one or two of the questions that I saw in the chat. So, okay, over to the presentation.
Thank you for the opportunity to share the findings from our VQUIN study on behalf of the trial investigators shown on the screen. By way of overview, the VQUIN trial was a randomized controlled trial comparing levofloxacin to placebo for 6 months amongst household contacts of patients with multidrug resistant tuberculosis or rifampicin-resistant tuberculosis. Treatment was given for 6 months during a treatment phase, and people were followed up over a total of 30 months after randomization. The study was conducted in Vietnam in 10 provinces, shown here, in close partnership with the National Tuberculosis Program and its director at the time, Professor Nguyen Viet Nhum. I'm pleased today to introduce you to 2 speakers who are going to talk to you about the microbiome study and the study looking at acquired resistance in VQUIN. The first of those is Dr. Annelise Howard-Jones, who's going to introduce the findings of the microbiome study. Thank you, Annelise.
Thanks, Greg, and thank you to the organisers for the opportunity to discuss the findings of our VQUIN microbiome sub-study. Next slide, please, Greg. So the aims of our sub-study were to characterise the impact of levofloxacin therapy on the taxonomic diversity of stool samples from participants in our study, as well as to analyse the longevity of these changes in diversity out to 6 months following treatment cessation. We also aimed to characterise the impact of levofloxacin therapy on antimicrobial resistance genes and the longevity of those effects, in particular fluoroquinolone resistance and ESBL genes. Additionally, we aimed to address the impact of levofloxacin on MRSA carriage in nasal swabs. Next slide. Thanks, Greg. So our participants were relatively evenly matched across the 2 study arms, and we enrolled 31 participants as part of the microbiome sub-study. Next slide. Thanks, Greg. So levofloxacin had a significant impact on taxonomic diversity in stool, which was not observed in the placebo group, as shown on the left and in the upper right figure. On 16S RNA analysis of the bacterial population, the significant drop in diversity at end of treatment compared to baseline did not recover back to baseline at 6 months following therapy, as shown in that top right figure. In the bottom right corner, we see that deeper metagenomic sequencing at the genus level, but not at the species level, showed the same significant drop in microbiome diversity at the end of treatment, designated as the T24 specimen in orange. Although changes over the subsequent 6 months did not reach significance in this analysis, likely due to the study being underpowered for this specific outcome. Next slide. Metagenomic sequencing also enabled more detailed analysis of antimicrobial resistance gene predominance in samples at each of the time points in the levofloxacin group. BLA-CTX-M, the major ESBL producing gene group, shown there in the middle, chromosomal fluoroquinolone resistance genes on the left, and DFR, a group of trimethoprim resistance genes on the right bottom corner, were all present in increased abundance at the end of levofloxacin therapy in orange compared to baseline in red. And recovery to baseline took between 1 and 6 months after discontinuing the levofloxacin therapy. Next slide, please, Greg. We adopted a machine learning approach to ascertain which AMR-associated genes were most overrepresented in the end of treatment samples compared to baseline, and these are highlighted here in yellow. So this analysis showed, as you can see in the black arrow there, that a key fluoroquinolone resistance gene, QNRS1, was overrepresented in the end of treatment samples, as well as a trio of genes indicated with those red arrows, which are known to be carried in an AMR cassette motif. Hence, it's likely that levofloxacin administration is associated with increased abundance of concerning AMR genes, which may carry implications for translocation of resistant bacteria and risk of invasive disease. Next slide, please, Greg. Looking now at nasal MRSA colonization, our study demonstrated that while participants with MRSA colonization at admission all harboured fluoroquinolone susceptible strains in the light orange shades of that bottom figure, Levofloxacin administration was associated with acquisition of fluoroquinolone-resistant MRSA strains in red. The fluoroquinolone-resistant strains all carried a characteristic PAR-C or topoisomerase 4 mutation, and all were of the strain ST188. Concerningly, ST188 is known to be associated clinically with increased virulence and invasive disease. And on whole genome sequencing analysis, we did find concerning virulence genes associated with pore-forming toxins and serine proteases in all of our ST188 isolates. Next slide, please, Greg. So in summary, levofloxacin significantly reduced stool bacterial diversity with long-term impacts. And in a gastrointestinal tract that is primed with resident ESBL-producing organisms, as we see in a high ESBL prevalence country such as Vietnam, levofloxacin pressure was associated with ESBL and fluoroquinolone resistance gene predominance, carrying a risk of translocation and invasive disease, and with persistence of that predominance for several months after cessation of therapy. Levofloxacin use also resulted in increased nasal colonization with fluoroquinolone-resistant MRSA strains that carried concerning virulence genes. So hence, in incorporating a broad-spectrum antibiotic such as levofloxacin into routine TB treatment and preventative regimens, these off-target effects on stool and nasal microbiomes may be a major risk-benefit consideration. Thank you, Greg.
Thank you very much, Annelise, and also acknowledging the people whose names are shown on this slide who contributed to this work here in Sydney, Australia, and in Vietnam. Our next speaker is Dr. Ori Solomon, who is a postdoc working at McGill University with Professor Marcel Baer's group. He's going to speak to us now on acquired drug resistance in the VQUIN trial.
Hello, my name is Ori Solomon. I'm a PhD candidate in the lab of Dr. Marcel Baer at McGill University in Montreal, Canada, and today I'll be sharing our findings on acquired drug resistance in the VQUIN trial. Over the course of the VQUIN trial, there were 17 lab-confirmed incident TB cases who had a positive TB isolate post-randomization, negative one before randomization. These isolates were shipped from Vietnam to the containment level 3 facility of the Research Institute of the McGill University Health Center here in Montreal. Of the 17, we were able to recover 11 incident case isolates. Of these 11, we were also able to recover 9 index cases that were matched to an incident isolate. These pairs were then analyzed, were whole genome sequenced and analyzed using bioinformatic tools. Two additional incident cases were also sequenced for genome-based resistance prediction. However, there was no available index case to evaluate acquired resistance or to detect acquired resistance. So we had set 3 criteria for our definition of acquired resistance to levofloxacin in the course of the trial. Firstly, we had to have sequenced a pair of isolates from the same household. So that is an index case and an incident case from the same house. The bacilli had to be genomically matched, with a genomic match being defined as having no more than 5 single nucleotide variants of high confidence across the genome. And finally, we had to found a susceptible genotype in the index case and a resistant genotype in the incident case, that is acquiring a resistance conferring mutation, a confirmed resistance conferring mutation in either GRA or GRB genes. So as I said, we had sequenced 9 index incident contact pairs. Of those, we found 6 pairs had genomically matched bacilli, indicating household transmission rather than community-acquired infection. And of those 6, we did not find a transition from a susceptible genotype in the index to a resistant genotype in the incident. So we found 3 different types of criteria failure. Either they did not meet the SNP threshold for household transmission. We had a transmission of a susceptible strain from the index to the incident, or we had an already resistant strain in both the index that was then transmitted to the incidence. So resistance was transmitted rather than acquired. So our key findings for whole genome sequencing analysis, we found in 3 of the 9 index contact pairs, the incident case had not been infected by the enrolled index case, but rather acquired the infection in the community. Among the 11 sequenced incident cases, 2 of the 2 in the levofloxacin arm were MDR-TB, whereas 7 of the 9 in the control arms had MDR-TB, with the other 2 being either isoniazid monoresistant or rifampicin monoresistant, meaning they could have qualified for first-line antibiotic-based TPT. In 2 of the 11 sequence incident cases, levofloxacin resistance genotype was detected. However, there was no evidence of acquired resistance to levofloxacin over the course of the trial. So with that, I'd like to thank Dr. Greg Fox and Dr. Marcel Baer. As well, I would also like to thank Fiona McIntosh, the manager of the Containment Level 3 facility here at the Research Institute of the McGill University Health Center, for help with isolation of the bacteria, as well as genomic DNA extraction for whole genome sequencing. Thank you very much.
Thank you very much, Ori. And just to conclude the presentation by acknowledging the wider VQUIN MDR trial team shown here, including Professor Nguyen Viet Nhum from Vietnam's National Tuberculosis Program, and also Professor Trinh Duong, the Executive Director of the Sydney Vietnam Institute, and other leaders from Australia, North America, and Vietnam. And you can see some of the institutions and the people who are involved on this slide here as well. So thank you for the opportunity to present today, and I look forward to further feedback, and we'll be happy to take questions by email after the presentation. Thank you.
All right. The next speaker will give a presentation on monitoring rollout of DR-TB preventive therapy and talk about the development of a master protocol for research project that will happen in the WHO Euro region. And the talk will be given by my colleague, Dr. Yohhei Hamada. He's an infectious disease specialist and also a clinical research fellow in infectious disease EPI at UCL Institute for Global Health. And he's one of the lead writers or developers of this master protocol. Please, Yohhei, your talk, please.
Yes, thank you, Lele. So I'm going to share our master protocol on evaluating TBT in real-world settings. So as we have seen in the presentation by Trinh, so we have a long-weighted evidence on the efficacy of DR-TPT, TPT for drug-resistant TB, shown in the combined analysis of 2 RCTs. However, we know having evidence of efficacy is not enough to scale up TPT based on our experience. There are often barriers on the ground that hamper the speedy scale-up of TPT. And therefore, it's important to monitor the rollout of TPT so that to understand feasibility and acceptability of new DR-TPT regimen, and then identify implementation barriers. Secondly, often trials include, only people who without significant comorbidities, and sometimes there are populations who are underrepresented, like people who are very old or pregnant women, and therefore it's important to continue monitoring of safety information through programmatic implementation, and that need to be conducted in a harmonized way, potentially through operational research. And lastly, it's still important to understand effectiveness of these new regimens, levofloxacin 6-month regimen, in a real-world condition beyond trial settings. So in order to facilitate research to fill the knowledge gaps, WHO Euro led the development of this master protocol on DR-TPT operation research. with support from us at UCL, WHOCC, and regional expert in WHO Europe. This master protocol is going to be implemented first primarily in 9 high MDR TB burden countries of WHO Europe. The master protocol will help standardize data collection across countries so that eventually we can pool data in the region and to generate evidence on particularly the real-world effectiveness of DR-TPT regimens. And also, master protocol will facilitate operation research to identify country-specific barriers to implementation of DR-TPT. Lastly, we knew from the experience of TPT in general, many countries have struggled to set up systems for recording and reporting TPT implementation. So we hope this master protocol and setting up operation research will help establish a recording reporting system for DR-TPT that can be used even after the end of operation research for programmatic monitoring and evaluation. So now I'm going to briefly summarize the contents of DR-TPT operation research protocol. The aim of this operation research is to derive real-world evidence on the rollout of DR-TPT among contacts of DR-TB through standardized data collection. The primary objective here is to evaluate the process outcomes, safety, and effectiveness of DR-TPT in target country in WHO Europe. I just want to emphasize again the importance of process outcomes because we already knew, at least from the evidence in RCTs about efficacy of DR-TPT, and that's why we want to emphasize the collection of process outcome so that to facilitate identifying specific barriers to implementation. Our target study population includes virtually everyone who are contacts of DR-TB, regardless of age, comorbidities, or treatment status, including pregnant women. That is because we want to measure TB incidence among contacts who do not start TPT so that they can be compared with people who are put on TPT, that they will allow us to measure the real-world effectiveness of DR-TPT. And also, by enrolling people who are not put on TPT as well, we are able to monitor implementation cascade, like uptake or screening investigation among contacts, so important steps in at least upstream of a cascade. We offer regimens in accordance with the WHO guideline. So our primary recommendation is obviously 36 months of levofloxacin in line with the WHO latest recommendation. And in case levofloxacin is not available, we offer an option of 6 months moxifloxacin. And in case a contact is exposed to a presumed source case that is resistant to fluoroquinolone, we offer 2 options, peraquinine-based regimen and tetramadine-based regimen. Just want to clarify, these are not official guideline recommendations. And these are based on expert opinion in the region because there is no clinical data on informing the effectiveness of the regimens. So that's the purpose here is to collect early data on their use so that they eventually inform the future trials evaluating efficacy of the 2 regimens. I'm here presenting process outcomes. These are essential to understand cascade by estimating proportion of contacts who complete each step so that to identify country-specific barriers. So the cascade starts from identification of contacts and then the confirmation of susceptibility to fluoroquinolone and the investigation contacts for TB followed by TBI testing if required according to country recommendation. That will lead to confirmation of eligibility for DR-TPT, and treatment is initiated and successfully completed, hopefully. And then we ensure follow-up completion for 2 years after the baseline. We also want to measure effectiveness and safety outcomes. We are going to measure TB incidence by year 1 and year 2. That is going to be compared between contacts who start and who do not start DR-TPT. The safety outcome include usual safety outcomes like serious adverse events and adverse events of special interest that are adverse events that are clinically important, specific to each regimen. We provide detailed guidance on what list of adverse events should be reported for each regimen. The guidance protocol will also give recommendation on examination that should be performed at baseline and at follow-up visits, on what safety events should be reported, and the protocol will also give guidance on sample size calculation and data analysis. So WHO Euro is going to set up a database to facilitate standardized data collection that will expedite the pooling of data at the regional level. That is important, especially because we anticipate small events rate for TB incidence, and pooling data is that's why important to ensure a study power, so that to get some early signal for effectiveness of these regimens. Data specification is aligned with routine data collection, so that the system set up for this operation research can be used after this operation research for programmatic data collection. We anticipate a country adaptation of the protocol because this is a master protocol. There is room for country adaptation. WHO Euro and we at UCL TB, as well as regional experts, are here to support our country for adaptation of this protocol. Protocol is already available upon request. So if you are interested, please contact WHO Euro for the master protocol. Thank you.
Thank you so much, Yohei. Let's just see if there's a nice question there for you from the chat. There's been a lively conversation about whether levo could be used for drug-sensitive TB. And important to note here a response from WHO that says, of course, the future of TPT is for shorter regimens, so we're unlikely to see a big trial looking at this. Might this be a question that we can answer from the kind of operational research that you have been telling us about? What are your thoughts?
Well, I think our master protocol is primarily focused on contacts of drug-resistant TB. I'm not sure if our protocol can give answer to that question about the use of levofloxacin in DSTP contacts. Maybe a similar operation research might be needed in other settings, but we can use the kind of structure of this operation research and adapt for that specific purpose.
Exactly. So that was my thought, exactly, that it's not necessarily going to come from this protocol that you have been presenting about, but operational research is a powerful tool for us to be able to answer some of these questions that will actually help programs answer these questions. Yeah.
I would like to introduce the next speaker, who is Maia Kipiani, who will give us country experiences on implementation from Georgia. Maia is a coordinator of TB management and control service at the NTP in Georgia, and she was TBI coordinator through the Global Fund TBI project in the country and deputy head of the NCTLD Scientific Research Unit. Over to you, Maia.
Hello, I'm Maia Kipiani, and it's an honor for me to present the Georgian tuberculosis program at this webinar. So over the last 2 decades, the epidemiological situation in the country has significantly improved, demonstrating the effectiveness of TB program methodology. So in 2023, there were a total 1,448 cases, out of which 1,144 cases were new. During the last years, the number of notified TB cases has been decreasing, and in 2023, the notification rate for all cases was 39 per 100,000 population, with 31 of those being new cases. However, DR-TB cases in Georgia are still alarming, and in 2023, the National TB Surveillance Database reported 8.9% and 24% of MDR-TB among new and previously retreated cases, respectively. This slide shows fluoroquinolone resistance among RR MDR-TB cases over the years. In 2023, there were 43 fluoroquinolone resistant and 81 fluoroquinolone sensitive cases identified in the country. The programmatic management of TB preventive treatment guidelines was updated in 2019 and are in line with the latest WHO guidelines and recommendations. The following at-risk groups are prioritized: people living with HIV, HIV-negative household and close contact, and other HIV-negative at-risk groups, including 9 subgroups. MDR-TB contact persons are eligible for TPT with levofloxacin, depending on the DST results on an index MDR-TB patient. The 2019 national guidelines for TBI management recommends that a 6-month daily levofloxacin regimen may be used for contacts of MDR-RR-TB, but fluoroquinolone susceptible index patient. But the national guideline will now be updated according to the 2024 WHO recommendations, including the following: for household and other close contacts of MDR-RR-TB but levofloxacin susceptible index patients, 6 months daily levofloxacin TPT regimen should be used. Contact investigation is a key component of TB prevention. As per national protocols, all contacts of pulmonary TB patients should be followed up and screened for TB, regardless of bacteriological confirmation. Those who are found not to have active TB, TB preventive therapy is recommended. This slide shows the number of total screen contacts throughout the years, as well as the number of contacts that receive TPT all regimens and number of contacts that specifically received the levofloxacin TPT regimen. In 2023, 2,889 contacts were screened in total. Of these, 396 patients received TPT therapy across all regimens, with 13 of the TPT levofloxacin regimen, including only 1 patient under the age of 5. I would like to highlight that the levofloxacin dispersible formulation is available for children in Georgia. Even with the updated guidelines, the coverage of TPT remains very low in the country. The main reason for this is the lack of availability of the TBI diagnostic test in the country. TST test has not been available for over 3 years in the country, and IGRA testing is available only at the National Center for Tuberculosis and Lung Diseases in the capital of Georgia. Though tests would be greatly help doctors in convincing patients to undergo treatment. Also, monitoring of TPT treatment remains a major challenge, especially in the small regional facilities where performing an ECG is difficult. And also, it is crucial to educate patients about the importance of TPT treatment. And the last, the improved TPT monitoring and evaluation systems throughout the country would be great. Thank you very much.
Thank you very much, Maia, for that. I think we will move to the next speakers.
Yeah, the next speakers is going to be a double act from Serbia. So it'll be Dr. Maja Stosic, who's a medical doctor and TB program coordinator in Serbia, and then Dr. Vesna Vekovic, pediatric pulmonologist who works very closely with the TB program. Please, your slides.
Greetings from Serbia, dear colleagues. We are very happy that we could share our experience, country experience. Well, Serbia is a Balkan country and upper middle income country with a disease burden decreasing of the communicable diseases while increasing as the most European countries in the non-communicable diseases. And TB program is based on the National Program on Communicable Diseases, and the programmatic activities focus on diagnostic, prevention, diagnostic, and treatment for tuberculosis, but also focuses on epidemiological investigation, contact tracing, and hemoprophylaxis on both drug-susceptible and drug-resistant TB cases. As you can see, Serbia is now a low TB burden country. In the last 20 years, decreased significantly the TB notification rate, also due to the Global Fund TB grant for 10 years. And the TB mortality rate also decreased, but as in all European countries, after COVID-19, notification and mortality rates started to increase. The majority of our cases is pulmonary TB, 80% culture positive, and what we assume as bad is that sputum smear cases is from 55 to 65%. The predomination of male is present among our patients, and also, as you can see from the slide, number of child and adolescent cases is low, but in the last 2 years, the numbers are increasing, given that most of the child and adolescent cases are from contact with non-treated adult TB cases. We are low MDR TB burden country as well, and from the period of in the last 20 years, the number of cases decreased over time, as you can see in the graphs. Coverage of first-line DST notification is about 60%, while actually, based on the laboratory data, coverage of first-line DST is 80%. And we are performing first-line DST for all drugs, while we are not now performing the fluoroquinolone DST. We performed only during the Global Fund TB grant and sent the samples to the supranational reference laboratory in Borsel, Germany. We have a prevalence of drug-resistant TB of below 1 or around 1% among new cases, while below 10 or 9 to 10 among retreatment cases. And based on the latest latent tuberculosis infection management guidelines of the WHO, we also developed the guidelines the same year, but we did not include the drug-resistant TPT in the national guidelines, and we do not programmatically implement the prevention among contacts with drug-resistant TB patients, and we are expecting the next year to develop a new guidelines. The need for DR-TST implementation occurred before COVID and also during COVID, when several children and adolescent cases appeared as close contacts with MDR-TB. And given we have no programmatic experience, we contacted the WHO ERS platform. It is a TB consilium, and asked for independent opinions, what to do with the patients. And also it was based on that opinion among our experts, in-country consultation was performed and decision was made to implement the regimens. And my colleague will continue related to the clinical aspects of implementation of the TST.
Hello, everybody. My name is Vesna. Thank you for invitation to participate in this webinar. We are here in the Children's Hospital for Lung Disease and Tuberculosis, Belgrade, Serbia. As Maia said, I will present one clinical case. How did it look in our practice? we had a young mother with MDR tuberculosis diagnosed in 2 years ago. She was hospitalized and treated in MDR TB hospital. Through household contacts, so we found out that she had 2 children, she has, and a husband. So children and husband were admitted at our hospital for further investigations. Both children, boy 3.5 years at that time, and girl 2 years, were both vaccinated at birth. First, we did quantiferon gold plus test, which came positive for both children. All other tests that we performed as TST, expert, and TB, they came negative. Chest X-ray and clinical investigation, they were all fine. All bacteriological testings came negative. So through collaboration, as Maia said, with European TB Consilium and our pediatricians, it was suggested that children should receive this drug regimen with levofloxacin and ethambutol. Mother was MDR, she was resistant for isoniazid and rifampicin. So is when some problems occurred. So we didn't have proper liquid form of the drug, child-friendly form of this drug for these young children, and they had to receive levofloxacin in our hospital just for 2 weeks. And when they were discharged, they couldn't get this drug because there was no legislation in our country for this drug to be prescribed for this young age, for these children. So it was decided that they should continue ethambutol for 6 months. They had no side effects during this treatment. They were coming to outpatient clinic for checkups every 2 months. And after that, they also were fine and they were not experiencing any signs of developing of a disease. Recently, we had 2 adolescent patients of 15 and 17 years. They are currently under investigations, but their tests came positive for isoniazid resistance. So we will proceed with PTP for their household members through the protocol. So thank you, and back to Maia to explain our major problems.
What lessons that we learned, that we have a good capacities of pneumophysiology, pulmonology, and pediatric TB services, both for drug susceptible and drug resistant TPT case management. Also good NTP coordination and communication with all the stakeholders and health service providers. But we don't have second line DST, which is a problem. No adequate drug formulation for kids. And also we lack indications for levofloxacin use of TB and drug usage in that age group. And we initiate some negotiations, but we receive response that it is not in SMPC as well of the EMA, European Medical Agency. So we will see how we can overcome this problem. And also we have capacities for the DR-TPT pilot studies implementation, and we are willing also, if it's possible, to enroll us. And we have certain emerging concerns. Although we are low MDR TB burden country, we are facing with a lot of number of migrants in the last and previous years, but especially last year and this year, with from high TB burden and MDR TB burden countries who are working in the public transportation, restaurants and factories from the India, Nepal, Pakistan and other countries. And we need to intensify DR-TB contact tracing and to implement programmatic TPT implementation for drug-resistant tuberculosis. Thank you.
Brilliant. Thank you so much for that experience from Serbia. Dennis, I think we can take a couple of questions, maybe just go straight to the panel discussion and invite everybody who has spoken today, because I know that we have about 15 minutes left. So if that's okay, some of the interesting questions to Serbia will probably come up during the discussion. So over to you then.
So here's the panel. So the speakers plus James, Seddon, and Anneke Hesseling, who have been also addressing questions in the chat. So James is a professor of global child health at Imperial College London and professor at Stellenbosch University in South Africa, the consultant in pediatric infectious disease at St. Mary's Hospital in London. And he has a research focus on children with TB, while Professor Hesseling is a distinguished professor in pediatrics and childhood at Stellenbosch University, clinical TB research in children in settings with high burden of TB and HIV in South Africa and globally for 18 years. And her focus has been on improved and safe TB preventive strategies for HIV-infected and unaffected children, adolescents, pregnant women, and households. So, so maybe like gauging a little bit from the number of questions that came in the chat. So we see concerns here about kind of either TPT with levofloxacin generating resistance, or else what to do in situations where suspected resistance to levofloxacin or maybe other drugs is high. So, so maybe we know this is not an easy question to answer, but I thought no one better than people in this panel to try and address this. And maybe I could start maybe with Anneke, and then as well to Yohhei to try and address this question. So over to you. Maybe very brief answers, because we have maybe 14 minutes till the end.
Thanks, Dennis. And I'm sure others can add. So the question is about levofloxacin for DR-TPT when there's a high prevalence of resistance to quinolones. In the TB-CHAMP trial, we excluded those with known documented quinolone resistant exposure. So we don't really have the evidence on that yet. There was about 15% overall resistance to quinolones. The Phoenix trial is looking at delaminid versus isoniazid for prevention in MDR-TB exposed household contacts. So delaminid would partly address that issue, but the trial is still ongoing. I think in brief, if you have documented exposure to quinolone resistant strain, there's no point in giving quinolone. If you don't know the exposure and you don't know the quinolone susceptibility, that's a problem. You should have it available. So my short answer is we don't have the evidence yet. If you have documented exposure to a quinolone resistant strain, there's very little point in giving levofloxacin. Might consider, there's no evidence yet, but might consider on an individual case basis, look at the susceptibility to other drugs and offer something or nothing, but we really don't have the evidence yet. High dose isoniazid is something that we would consider based on the DST and the mutations.
Yohhei?
Hi. So unfortunately, there is no data about the duration of drug resistance when we are given new regimens containing beta-alanine or delamide. But because our protocol is operational research, so our spirit is to document what happened in programmatic settings. So if countries do recommend the new regimens in their own country, we want to monitor and collect data through the harmonized data collection. And at the same time, we also offer some guidance on investigation that should happen, like chest X-ray, so that to rule out active TB confidently, and also so we recommend rigorous support for monitoring, support for adherence, which is daily video supported therapy. So we do recommend some measure to mitigate the risk for generating drug resistance, and also we want to just document what happened in those settings, whatever it's recommended by countries through standardized data collection.
Thank you, Yohhei and Anneke, for those replies. So there was also a question about the duration of the follow-up of the pairs in the VQUIN trial. So I don't know if you know about this, otherwise we can address this directly to Greg and Annelise. Okay, if there's no replies from here, then we can we can go to the next question, Lele.
Yeah, I just want to stay a little bit still with this benefit risk concept. The talk certainly from Greg's team, which looked at microbiome data.
Okay, I think Lela's having some connections problems because she's connecting from outside Britain. So okay, so yes, so maybe another question that we wanted to.
Yes, I think Lele is back now.
Is she back? Lele, are you back?
No, she's gone again.
Yeah, she's told me that she has a bit of issues. Okay, so one other issue that came up, I think, repeatedly was about the diagnostics, right? About what you do if you don't have these tests of TB infection, which of themselves are not too satisfactory. Okay, let's try to connect again. So maybe some comments from the panel about the diagnostics. So I think from Serbia we heard that that there were some issues, right, to access diagnostics in time. Yeah, Lele, sorry, I'm seeing you back, so I jumped onto another question on diagnostics that I found.
Yes.
Yeah, so I was wondering whether Serbia can give us a bit more details about the availability and maybe trying to get some of these newer TB skin tests, like CYTB was being mentioned, I think, in the chat here by Christian.
Well, in Serbia, we have the problem was only second line DST, while TST, the IGRA tests are widely available. And also the conventional diagnostic in Serbia is a little bit low for both drug-susceptible TB and drug-resistant TB as well, because the availability of WHO recommended rapid test is not access countrywide, but still in Belgrade, in the capital city, we have a HIME test, which is a PCR test for detection of resistance to first line. So we do not have that kind of problems, but we are facing the problems with the second line DST, and now we are in the phases of negotiations to develop TB elimination plan. And within this elimination plan, we should focus on the rapid diagnosis and also to the second line, to availability of second line DST, and also for not only for those, but both for beta-kilin and delamanid, because we are implementing that regimens in Serbia, and we should have also that possibilities to test for resistance.
Okay, thanks. And maybe, I don't know, Maia from Georgia, if she has any other views on the availability of tests of TB infection.
So we have the DST results for first and second lines are available in Georgia, but unfortunately, as I mentioned in my presentation, we have the lack of availability of TBI diagnostic test in Georgia. So TST, yeah, has not been available for Georgia, and IGRA test is available in the capital of the country.
Okay, so thank you very much. Yes.
May I just add something about the question about the test of infection specifically? I just wanted to clarify, Dennis. May I go ahead?
Yes, please go ahead.
Thanks. So in the pediatric study in TB-CHAMP, which predominantly looked at children below the age of 5, a test of infection or positive test was not required. So all children below the age of 5 were randomized regardless of a test of infection, because we really felt that really reflected what was available in that context, which is a high burden setting without availability of test of infection. And so it really looks at the risk is high in kids below the age of 5. So regardless of a test of infection, they were all included. I want to also just state that in the children who went on to develop TB disease in TB-CHAMP, that half of them had a negative test of infection. We did do an IGRA test, we just didn't randomize on that basis. So using the latest generation IGRA, we would have missed out half of children who could have actually benefited from levofloxacin if we get randomized based on a positive test of infection. So as you can see, the guidelines say offer levofloxacin regardless of a test of infection in kids below the age of 5, and that's actually what the evidence shows. So because that's again risk assessment, and in fact the IGRA would not have been useful at all. So it's not just that it would pose a barrier, it actually would miss kids. And so I think that's quite helpful information, so that we should not have a test of infection be an obstacle to access TPT in a high-risk contact who's been well investigated. Thanks.
Okay, thank you very much. Lele, can you?
Dennis, hi. While I'm on and Zoom is
You're
behaving.
back strongly. Okay.
Yes, I have a question for Avinash or any of the program managers. It's about how to interpret that microbiome data from Greg's study, Avinash. I mean, this clearly affects, the kind of benefit risk, so I'm just wondering what the messages are to programs. And there was a question in the chat about whether any monitoring should then be done on stool and for nasal colonization. So what are your thoughts on this? How, what are next steps?
I think maybe the microbiologists on the panel can respond better, but this issue was discussed by the guideline group, and but it wasn't felt necessary to include it as one of the issues that the programs need to monitor for as of now, because the data that was presented, there is for now I don't think there is a programmatic implication. We need to understand a bit more, but I will let other panelists from the trial to respond. Maybe Dennis, if you want to add.
Yeah, I think the numbers that we had in the trial and the results were still early, so they were not complete. So I think there's more complete data now, but under programmatic settings, because I saw the question as well before. So under programmatic settings, one would expect these events to be rare, relatively, right? But people will go down with TB even if they have taken the TPT. Some will, and in that case, one would also want to get an antibiogram from that person, either because they were sort of primarily infected with a bug which might have been different from the one of the presumed source case, but also because of possibility that there is an emergence of new resistance in it. But again, there isn't direct evidence that TPT is producing or favoring the emergence of resistance, or that it's leading to increased levels of resistance in populations where it has been used. So that we don't have that direct evidence yet. But that's a good point.
Yeah.
So I think we're nearing really the end now. I don't know if there's time for any more maybe comments or
just one more quick question, I guess, about picking up from the presentation by Serbia, which highlighted a possible concern around the access or availability of pediatric disposable formulations. I guess, some last thoughts from the panel about how we can avoid, availability of these formulations hampering programmatic implementation. Any thoughts on that?
Yeah, I'm happy to give brief thoughts. So the TB-CHAMP trial, the entire trial was conducted with the adult formulation, 250 milligram. It was surprisingly acceptable and well accepted in kids. So from a programmatic perspective, that's actually good news, because we didn't use the Mercedes-Benz formulation for the trial. We used what was routinely available then. And you will see that in the operational handbook, there are now dosing guidelines for the adults and the pediatric formulation. And so you can use whichever one you have available without the formulation being a barrier to access.
Thank you. That's good news, huh? James, I have a question for you to do with trials. Just thinking ahead about the landscape, future trials. What's the likelihood that we will see shorter regimens? And should we, for DR-TB prevention, should we expect one?
Yeah, look, I mean, there is a trial very much proposed by the USAID trial group that's looking at a month of bedaquiline. I think that'll be interesting. I think there are concerns of a long tail and potential drug resistance with all these things, but that I think will be a very exciting trial to see what that happens. I mean, there are always trade-offs. I think that if we gave preventive therapy for 2 years, we'd have a really low event rate. If we gave it for 2 weeks, we'd have a lower. At some point, we have to say, this is, you know, on balance good enough. So I'm sure we could give levofloxacin for 3 or 4 months, and it would be better tolerated. It would be a bit cheaper, but it would probably be a little bit less effective. The question is, we as a sort of society need to decide what is good enough. We have these quite I think random non-inferiority designs where you kind of set a boundary beforehand. I think that more of the duration randomization designs might be attractive to kind of actually calculate what the inflection points are in these different durations of preventive therapy, because otherwise we have very static, you know, we pick a time and we then do it. But look, I think we should be giving shorter regimens. I think that giving the 3 HP, the 1 HP in drug susceptible TB, it does tell us, and for giving to a well patient, giving 6 months therapy is really, really hard, I think. Not sure I've answered your question.
No, you have. You know, have other questions around PEN-TB, because that seemed to be coming out a lot in chat, but I think that's all we have time for today. So certainly from me, I just want to thank everybody for joining the panel, giving absolutely amazing presentations. I think we have an amazing opportunity to address an important gap, but clearly from the presentation as well, I can understand that this is no time for complacency, and we have some challenges to sort out, and we need to bring everyone else along. Dennis, your last thought.
Yes, so my last thought is again to thank everyone for this. It was an excellent session, and it generated a lot of interest. We stayed with a huge number of people till the very end. So once more, we will, as WHO, will be looking at the evidence, we'll be looking at new trials. There's some being completed even next year, not in the area of DR-TPT, but in other important areas. And we will be updating our guidance and operational handbooks accordingly. So thank you very much, and keep promoting TPT, and hope to see you soon again on another webinar or in Bali to keep discussing this and more. Over to you. Thanks.
Thank you.
Thank you.
Thank you.
Thank you. Bye.
Okay.